Hello, everyone, and thank you for watching our presentation. We are excited to present our work on a novel Internet of Things system for patient-centric pressure ulcer prevention using sensor-embedded dressings. My name is Sachin Rangarajan, and I'm one of the UCSF engineers working on this project. This project represents a joint effort between the University of California, San Francisco Department of Surgery, the University of California, Santa Cruz Department of Engineering, and the VTT Technical Research Center in Finland. And I'd like to thank our collaborators for their wonderful efforts in bringing this project to fruition. So to give a bit of background, pressure ulcers or pressure injuries are localized damage to the skin caused by prolonged pressure applied to an area of the body. Normally, capillary pressure ranges between 16 and 33 millimeters of mercury. External pressure that is greater than this capillary pressure occludes the vessel, preventing blood flow and causing anoxia to the surrounding tissue. The current hospital standard involves turning patients every 2 hours with the goal of redistributing this pressure fast enough before injury occurs. However, this 2-hour intermittent manual repositioning effort often fails to capture these anoxic events in time. And if pressure continues for a critical duration, cell death will occur, resulting in soft tissue necrosis and eventual ulceration. These injuries occur, as you expect, near areas of bony prominences. And here's some of the statistics related to pressure ulcers. The important point here is that the current standard of manual repositioning is not sustainable. Nurses must repeatedly and blindly turn patients and currently have no means of determining whether or not their turns are effective. And in the cases that the turns are not effective, the results are devastating, as you can see in this progression of stage 1 through stage 4 ulcers here. So clearly, the current standard can be improved. In fact, a study involving over 500 patients at a hospital that placed an accelerometer on the patient's chest found that there was low compliance with the turning standard. Fewer than half the patients were actually turned to the minimum angle, and fewer than half the patients remained in the turn position for more than 15 minutes. Another study found that by placing a pressure mat on the patient's bed, there was inconsistent turning between nurses, between the same nurse turning different patients, as well as between individual nurses turning multiple patients. Critically, they found that there are areas called triple jeopardy points that remain at high pressure even after nurses have performed the turn and believe that pressure is adequately relieved. The conclusion derived is that standard turning by experienced ICU nurses does not reliably unload all areas of high skin-bed interface pressures. So this leads us to our solution, the IoT patient-centric system. This involves a smart wound dressing that combines both an accelerometer with a pressure sensing grid that, most importantly, is going to be placed on the patient rather than the bed. This allows for real-time continuous monitoring of the patient, as well as measurement of pressure accumulation on the patient over time. This will send data to a software system that is integrated with the electronic medical record and uses objective data derived from the EMR to estimate the patient risk. Lastly, the UI will be displaying this information through an AI-assisted ideal turn system. The system represents the next generation of the sense, store, and analyze software that was described in the following citation. This work is a work in progress system designed to use a database of ideal turns to evaluate current turn effectiveness and ensure consistent and repeatable turning that effectively alleviates pressure. For this paper, we're going to be focusing on the proof of concept of the smart sensor wound dressing and the preliminary turn evaluation system. So onto the smart wound dressing. Creation of a large area conformal patch through conventional flexible electronics manufacturing methods is challenging and uneconomical. To overcome this issue, instead of using conventional PCB fabrication, the patch was realized using printed electronics technology. The patch layout was processed with a roll-to-roll screen printing line with some of the relevant parameters shown in this table. You can see here a stack diagram of the patch, as well as some of the calibration results from benchtop tests. We were able to determine through these preliminary tests that the sensor was able to accurately measure force in the physiological range, as well as measure the 3-axis angular position using accelerometer, and transmit the entire data stream in real time via Bluetooth. Critically, this entire system was soft, low profile, flexible, and embeddable in a wound dressing without risk to a patient. And you can see in the bottom an example of one of our engineers working with this device. We performed a preliminary observational, descriptive, healthy volunteer study with 5 volunteers. After obtaining IRB approval, adult volunteer subjects were recruited with informed consent. An experienced ICU nurse and nurse educator performed the turning procedures following the standard care protocol. Each volunteer was placed supine on a Hill-Rom ICU bed with the head of bed tilted at 0 degrees and with the pillow placed under the head and each arm. The volunteer remained supine for 2 minutes. After 2 minutes had passed, the ICU nurse and an assistant turned the volunteer by lifting the volunteer to the left and wedging pillows under the right side of the volunteer. This left position was maintained for 2 minutes. After 2 minutes had passed, the volunteer was then turned to the right side using the same ICU turning technique. Lastly, the volunteer was returned to the supine position. The head of bed was then raised 30 degrees, and the supine left and right repositioning cycle was repeated for 2 minutes in each position. Pressure and accelerometer data were continuously collected from placement of the patch through removal of the patch. This data was fed into the previously described Sense, Store, Analyze, and Visualize platform. For this paper, we created a preliminary analysis tool with the goal of identifying patient position as supine, left lateral decubitus, or right lateral decubitus, using a combination of pressure and accelerometer data. This analysis was done using a simple logistic regression model trained on the volunteer data. Because of the small set of initial 5 volunteers, we iteratively trained and evaluated the model by excluding 1 patient at a time as the validation dataset. The remaining patient data was then split 80%, 20% into training and testing data, which was used to evaluate the accuracy of the model and evaluate the extent to which the model might be overfitting to noise in the small sample. This was then compared to the validation volunteer in each iteration, who represented a patient that the model had not yet seen before. While the training data was labeled during the experiments, it contained a significant amount of noise around transition points when the patient was turned. To this end, we explored the unsupervised cleaning of the training data to remove extraneous samples. We used an approach based on isolation forest model for the data cleaning. To prevent bias, no data cleaning was done on the test or validation data in each iteration, but only on the training data. The training data were transformed into several features, such as normalized mean pressure along a 3-way horizontal split, an objective mobility score, which is determined using single value decomposition. As we used a logistic regression model, the choice of features was critical for expressing non-linear relationship between the data and the result. It also served the dual purpose of combating overfitting of the model to noise patterns present in each patient's data. We also added a metadata feature which provided the patient's height and weight, which is something which would be readily available in clinical use. To evaluate the choice of hyperparameters, such as the choice of training features and whether or not to clean data, we considered the mean of all validation accuracies for that model. We believe that this is the most adequate metric that represents the model's expected performance in clinical use. We performed a grid search over all combinations of hyperparameters, and we were able to achieve a mean test and train accuracy of 95 to 99% and validation accuracy of 55%. We expect that as we acquire additional training data from different subjects beyond the initial 5 volunteers, the model will be able to detect patterns in the pressure data that'll enable for more accurate predictions in the validation step. And more importantly, this indicates that even with minimal data, we are still able to make somewhat accurate patient position predictions. The data cleaning and pre-processing step produced noticeable accuracy improvements for certain feature choices, further indicating that more data is required to generalize the model and produce higher accuracy predictions. Ultimately, we envision a system that derives a pressure injury prevention protocol unique to each patient by using objective factors that include real-time sensor data, labs, vitals, and the patient's medical history. The system will continuously monitor a patient's risk of pressure injury within the hospital, at long-term care facilities, and at home. This continuous monitoring in conjunction with objective clinical risk factors can be used to provide actionable information that intelligently and effectively enables caregivers to prevent pressure injuries from occurring. I would like to again thank our collaborators at UCSF, UC Santa Cruz, and VTT for creating this novel patient-centric ulcer prevention platform, and would like to thank you for the opportunity to present our preliminary results at this conference.